Hello, everyone, and welcome to this training PowerPoint for our field nurses. In this training, we're going to talk about why we do trainings for nurses, the nurses' goals in the field, the patient's rights and goals, and what we're trying to achieve with that, proper visit protocols, proper documentation, any unexpected deviations from the proper visit protocols or documentation, and then a summary. So first, I'd like to explain why we're doing this training and why we're going to begin doing regular trainings for our field staff. First of all, it will help to address any recent patient complaints and also prevent any future patient complaints. Same thing with pharmacy. This will address recent pharmacy complaints and make it so that we can prevent any future pharmacy complaints. Internally, we do our own documentation reviews, and we've noticed some patterns that we want to address and hopefully get us all on the same page. Also, there have been some visit issues with time spent in prep or on the end of the visit trying to clean up and leave, and even during the infusion time. So all of the times have been an issue pretty much across the board, and we're going to address that. And titration issues. It's very important when we talk about titration to really understand why we're following titration orders from the pharmacy or from the doctor. So first, let's talk about nurses' goals. Primary, and nothing above this is patient satisfaction. Of course, we all know our skill levels have to be up to par, but for argument's sake, for this training and for working in the field and for being a part of this agency and any agency you do join, patient satisfaction is primary. That's our bread and butter. That's what pays our agency so that we can pay our field staff. And we want to make sure our patients are getting top-notch skills and attitude and bedside manner. So it's not just going in and starting IVs, it's really the whole package. We have to be aware of our skill levels. So if we have only learned, let's say, a portacath access or a sterile dressing change for a PIC or a port, we want to ask, if we're not already asked by the agency, but ask if we can shadow a nurse just to make sure we're comfortable and confident in our skills. Please don't ever go out there and experiment on your patient and let them be the first one you've done a skill on without having another nurse by your side. Ask questions. Don't be afraid to ask questions. Don't guess. Whatever the issue is, whether it's a medication, whether it's the dose, whether it's how long the infusion is supposed to be, whatever the question is, there's no question too small or too dumb. We need to know that you know everything that's going on, and please ask the agency just to make sure that we know everything that is supposed to be going on. Please be ethical when you're with a patient. Doesn't matter, again, how small the issue may seem to you, but just please be ethical in your nursing skills and in your human decency and bedside manner attitude. Please be polite and respectful. This is the patient's home we're going into. So we want to be respectful of the patient, whatever their needs are, whatever their limitations are. We have to be respectful and polite about that as well. Please be clean. Clean your workspace before, during, and after you're with this patient. We do not want to leave and have patients call us, which they have, to say, patient left all my trash, or the patient ate and left all the food, or the crumbs, or the containers. Please just be aware of the fact that you are a guest in the patient's home and clean up your workspace. Please be accurate. This is accurate in the medications. This is accurate in your time. This is accurate in your documentation. And we're going to go into all of the details, but we want to make sure that what you do is what you document. What you've documented is what you've done. No disparity between the two. Okay, let's talk about patients' rights and goals. Let me move this out of the way a little bit. Okay. Patient has the right to be treated with respect and with dignity. Again, this is primary for the patient. They are opening up our home to them. The patient really deserves our utmost respect and dignity. And I know as nurses, we're taught that, and we're nurses so that we have that empathy and that compassion. But sometimes it's easy to forget, especially when we have a patient that's argumentative or a patient that's got some issues with their own attitude. It's very easy to forget that we are in their home and we're working for them. Patient has the right to receive their medication properly and appropriately as ordered. Again, don't assume anything. Ask questions if something doesn't match. We want to make sure we're doing the right thing. Even recently, I was in a home for a patient, and what was delivered was not the same dose that I had. I had to call the agency and they had to send me an updated order. So don't assume there was a change. It could have been an error. Or don't assume it was an error. It might have been a change. Don't just give what's in the home and assume it to be correct until we check. The patient has the right to be able to request a change in their nurse if they're not satisfied for any reason, and don't always take it personally. Sometimes the patient just would rather go to sleep and they have a nurse that is very chatty. Sometimes the patient wants more attention and they have a nurse that just buries their head in their paperwork or on their computer, so they need more chatty. So sometimes it can be just that simple. And hopefully it's something that simple. We don't want to be sending a new nurse because the patient wasn't satisfied with their skill level or their cleanliness or their bedside manner. The patient has a right again to not have to clean up a mess after their treatment. So again, be aware of your surroundings, be aware of your workspace, and just tidy up before, during, and after anything that you're doing. The patient has the right to feel safe and comfortable opening up their home to you. The patient signs up with a healthcare plan. The healthcare plan is what is dealing with the insurance company. The insurance company hires the pharmacy. The pharmacy hires A plus. A plus hires you to be sent out. So ultimately, if you look at the hierarchy, we are being employed by the patient. So as such, we want to make sure that we are completely following their lead, following their opening their home. We really want to make sure that they feel safe, secure, and comfortable with us walking into their home. And just please keep remembering that we are a guest in their home. And anything we do, we want to explain and just make sure that we are doing the utmost. If for any reason you see that your patient is feeling a little bit lacking in safety, security, happiness, whatever it is, we want to ask them, is there something that I can do for you? Is there something you need? Or is there something I can address next time that might make you feel a little bit more comfortable? Maybe the patient didn't verbalize their needs. So be aware of the patient's maybe facial expressions. Maybe they're in pain and they don't want to say anything. So ask, do you need some of your medication right now? Do you need me to help you adjust in your seat or in your recliner? So just keep making sure that we are doing the best that we can do for our patient. All right, let's talk about proper visit protocols. We want to make sure that we're scheduling this visit. Most of the time, we will know that we have this patient coming up a week or so in advance. As soon as you know that this patient is coming up for you, if it's your regular, you want to make sure you know which day of the week. And they want to know which day of the week so that they can arrange work schedules or doctor's appointments or other appointments that they have. So you want to schedule this at least the week prior. The day before, you want to confirm your appointment with the patient. They have the right to know when you're coming. I like to give most of my patients usually a 1 hour, sometimes even a 2 hour window. So if you have this patient as the first patient of the morning, you can say, I'll be there about 8 a.m. or between 8 and 8:30. But if they're your second or third patient, you don't know if you're going to get stuck in traffic or if you're going to have a delay from the prior patient or if they're going to be done early or if you had to skip it. So give them a 1 to 2 hour window. And so generally, if you think you'll be there about 11, say I'll be there probably between 10:30 and 11:30 or 10 and 12, just so they know when to expect you. And then please let them know that you will text them or call them when you're on your way, so they know when to take the medicine out. They know maybe to run and change or eat something before you come. So just, about a half hour out to an hour out, just please text them and say, I'm on my way now. Or if they're not somebody comfortable with texting, just give them a quick call once you're in your car saying, I'm on my way now. I'll be there 30 minutes, 45 minutes in 1 hour. And remind them. Sometimes you have to remind your patients, please take your medication out now. I'm on my way. Some patients, and these are only the ones that you've been seeing for quite a while, may want to take their pre-meds, especially please only do this with the patients that you know are easy access peripheral sticks or easy access portacaths. You don't want somebody to take their medication ahead of you getting there and then things are missing or they're a difficult stick, it's taken an extra hour. You don't want to run into that trouble of not being able to access them for whatever reason. So this is only with those patients you're familiar with. They know the supplies are there. You know you're going to walk in and be able to access them immediately. Every now and then, you don't know, you're just covering for another nurse. The nurse called out sick. So, of course, you can't confirm a week in advance or the night in advance. But please, if you're called by the agency to say a nurse had a flat tire or a nurse couldn't make it today, can you go see this patient? Please give the patient a heads up. Let them know you're covering for another nurse. You'll be there at such and such a time. Again, if you can give them a window, give them a window, or just say, I'm on my way now. I'll be there in 30 minutes, or I'll be there in 45 minutes, whatever the case may be. But it's just proper and polite to give the patient a little bit of a heads up if possible. Prep time. Now, I know this is a real thorn in a lot of people's sides. The pharmacies are very strict about this, and they're starting to come down on the agencies. So now the agencies have to come down on the field nurses. Prep time is usually about 30 minutes. Now, there are exceptions to this, and we'll talk about that. But your prep time is walking in the door, greeting the patient, getting your supplies together, getting them all ready, unpacking the box if you have to, not opening up the supplies, but just making sure the supplies are there, then washing your hands. Please make sure you're all washing your hands when you get there. And then you can unpack the supplies and make sure everything is there. Again, if your patient did not take pre-meds before your arrival, then when you walk in, they can take their pre-meds because they know you're there, they know you're going to be accessing them, and they're starting within 30 minutes. So now they could take their Benadryl or Tylenol when you walk in because you're going to take that 30 minutes. So once you lay everything out, you check the medication against your labels and your doctor's order, you know everything is there, you know that you're setting up okay. Now you can check the patient's blood pressure. If it's somebody that you know that's a regular, um, you can do it in that order. If it's somebody you don't know or somebody you know that spikes a blood pressure or has high blood pressure to begin with, please take their blood pressure before you have them take their pre-med. Again, there are these one-offs, and if you have any questions about anything I'm saying in this entire PowerPoint, please get a hold of Betty or Alberta, however you know her, and she'll get a hold of me. We can email back and forth any questions that you have about any of this. And I can go over all of these little one-offs, but for general purposes, it is about 30 minutes. If a patient is extra difficult, or if a patient has a lot of bottles that have to be transferred into a transfer bag, then of course your prep time may be a little bit longer. But for argument's sake, let's just say 30 minutes, tops 45 minutes. If you have to do a second stick on a patient, then it may be about 45 minutes. So just make sure you're not overusing your prep time. It very rarely takes more than the 45 minutes to start. And if it is taking somebody regularly, routinely over the 30 to 45 minutes, then we will probably have you shadow another nurse, or Amy even come and shadow you to see what can we do to kind of shorten that. Because again, the pharmacies are starting to crack down because um, the insurance companies are starting to crack down, and they're looking at what they're paying out, and they're looking to save money. So of course that rolls downhill to all of us field staff. You want to make sure you're checking all your orders again for consistency. And I'll probably say this a few times. I know I'm repeating this. Check your MD order, check the pharmacy label, check the bottles that the medication and the supplies are coming in. Make sure that everything matches. Make sure there's no change in the drug. Make sure there's no change in the amount, the dose. Make sure that nothing else has changed. Even in the pre-med, if there's a change, make sure you have that doctor's order and the pharmacy is aware of it and everything is there. Please, 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 this is critical. We're having a lot of pharmacy complaints on titration time. Please follow titration orders. I'm going to give you a couple of instances where we don't follow titration time, but you don't make that ultimate decision without letting the pharmacy know, without letting the agency know. And here are those times. The doctor will usually write an order that just says over 2 hours, or not even as specific. They may just say over up to 5 hours every 3 weeks. It's the pharmacy that may determine that titration time. The only time you can change a titration time, and again, you don't do it on your own without notifying the agency and the pharmacy, is sometimes the pharmacy will write, for instance, a titration of 30 for 15 minutes, 60 for 15 minutes, 90 for 15 minutes, 120 for the balance, and then there may be an extra line that says, may titrate to a max of 150 if patient is tolerating it, or as patient tolerates. So again, that initially comes down to our assessment, but this is never going to happen on the first or second, sometimes even the third time that you're with this patient, because we want to make sure that the patient is tolerating it. And we don't know on the first or even the second if they're going to have a reaction. So the first time, probably the second and third, you're going to follow up to the 120. If the patient's blood pressures remain stable, if their pulse rates remain stable, if they did not have a follow-up after their infusion with a headache or body aches or extra fatigue or anything out of the ordinary, then we can call the agency and call the pharmacy and say, patient tolerated this for the first few sessions. Can we bump this up to the 150 and try it? The pharmacy will give the okay, and then and only then you can bump that up. The time to slow down the infusion is only if the patient is having a reaction, or you have to stop and pause the infusion for any other reason. For instance, the patient walks with a walker, so they can't wheel an IV pole while they're wheeling a walker. So you might have to pause that infusion for 5 or 10 minutes, sometimes up to 15 minutes, depending on how slow the patient walks or how far the bathroom is. So of course there's that. But if there's any kind of a side effect happening, patient's developing a monstrous headache, patient's blood pressure is spiking, stop that infusion. We're going to be monitoring their IVs, but it is not up to the field nurse when to restart that infusion. That's when you notify the office, and that's when you notify the pharmacy. Patient's blood pressure spiked. I'm pausing the infusion. Let me know if I can continue it or not. So of course, excuse me, we're going to have to let the pharmacy know, did that blood pressure come back down? Is it staying high? Because then what's going to happen is the pharmacist will have to notify the MD. The MD may say, run it much slower. The MD may say, stop it for today, and we're not going to give this medication. So the nurse's only job is to stop it, notify, and document, and then wait for the further orders for what to do. Any pump changes, just as the titration changes that I've mentioned, again, we can't make that determination unless we get approval from the agency and notification to the agency, and then approval from the pharmacist. If for any reason changes need to be made, it's going to come from the pharmacist. Post-infusion cleanup is part of your visit protocol. Again, I know I've discussed this. Check your workstation. Make sure if you've eaten, you've contained yourself in your own little space and cleaned up after yourself. All of the wrappers from all of the patient's supplies were disposed of. What I like to do is I usually take that large plastic bag that the medication comes in, or that some of the supplies come in, usually a large plastic bag. As I'm working, I'm putting the garbage into that. So I don't have a big cleanup at the end. I'm doing that in the moment while I'm opening and setting everything up, so that by the time the infusion is running, I'm ready with the trash bag, and the only thing left is the bottle or bag at the end and your sharps. But usually everything else is done in the moment. So please, the post-infusion cleanup should be almost immediate. By the time the infusion is over, you should only have your last 5 or 10 minutes to gather your belongings, pack up your computer. I usually do that when there's 10 minutes left. Ask the patient how they're feeling, take their last blood pressure right at the tail end of the infusion. Everything is packed up, garbage is trashed except for your peripheral IV. If you're pulling that goes in the sharps, of course. So really, we allow up to that 15 minutes to make sure the patient is okay, but it should really be within 5 to 10 minutes that you're walking out the door. When to call the agency or pharmacy, I know I've said that. If there's any questions, if there's any discrepancy between what is ordered and what is delivered, if something is missing, if the patient develops any side effects or any symptoms or any adverse reaction, if you've had to pause the infusion for any reason, and then if you're unsure of anything, if there's any difficulty with accessing the patient so that you're spending extra time or you've had to pause it extra during the infusion, you let us know in the moment. We don't want to be surprised when we get a timesheet back and a 3-hour infusion is now being billed for 6 hours or 7 hours. We want to know in the moment, while you're still in the patient's home, what's going on, what's the delay, what's the pause, and then we will give you the ultimate approval, whether to keep extending the visit or whether to just leave. Okay, we're going to talk about proper documentation. I know this is a big issue with the pharmacies trying to read our paperwork, and with the doctor's office. Things have to match. Everything has to match and everything has to be appropriate, because the doctor wants to know what's going on with this patient. The pharmacy wants to know what's going on with this patient. The insurance company needs to know what's going on with this patient. In case there needs to be a change, there has to be a reason for a change. Otherwise, the insurance company won't even approve a change for a patient. Your time of arrival, your time of departure must match on all your pages. So on your route sheet and on the first page of your visit, that's where your arrival and departure times have to match. Please make sure the date of birth, date of service, and the date of the next visit are filled in. Now, if you're just a fill-in nurse and you're not going to see this patient the next time, still put in the next visit, because the agency needs to know when to schedule that patient on the calendar, and the pharmacy needs to know when to send the supplies. So even if you're not the nurse going in, everybody else needs to know the next visit for this patient. So please make sure that's corrected. And the date of birth, because there are patients with the same name, so we want to identify them by their date of birth. The correct diagnosis, again, the pharmacy needs to know this just so they can double check and make sure the medication being ordered is correct. And the insurance company must know, and the doctor needs to know when they're opening this up. Oh, am I looking at the wrong patient? Because they don't have MS, they have CIDP or something going on. So please make sure that the diagnosis is correct. And the diagnosis is, why are we in their home? They may have cellulitis, they may have an infection, and they may be on another antibiotic. But if we're going in because they have MS and we're doing an MS drug, then MS is what goes on the diagnosis box, not that they have a UTI, not that they have cellulitis, unless we're giving the specific IV for any of those other reasons. Sometimes the patient has cancer and we're going in for hydration. So dehydration would be the diagnosis, and then you can put cancer as the secondary diagnosis. Please make sure that you put the correct access, whether it's a peripheral, a port, a PIC. Number of attempts is important, not because we want to make sure of your skill level, but because we want to make sure the pharmacy, if you've used 3 insights, we want to make sure the pharmacy knows you've already used up 3, you need more probably, and you're going to document in other places that this was a difficult stick or that the patient was very dehydrated. So we want to make sure we get the next batch of adequate supplies. And any difficulties you're having or any difficulties the patient's having, we really want to make sure that we're documenting that. Everything has to go on there. The vitals, I'm going to show you on a page next where everything has to get documented. But just know right now, we want to continue to monitor vitals. If their vitals are regular, we need to know that. And if they're spiking any specific pulse rate, blood pressure, temp, we want to make sure we're monitoring. If the infusion is paused for any reason, we must document so that, again, we have a reason to explain why a patient was paused for an extra 15 minutes. This is why I was in the home a little bit longer. Sometimes the patient, if you're on a 5-hour, 6-hour IV, trust me, that patient's going to be paused for a good 2 or 3 times to get up and go to the restroom. So now we can say to the pharmacy, we're spending an extra 45 minutes to an hour with this patient above the titration time, because they're asking, and we have to explain that. Okay, so here we have an example of an IV assessment page. So again, as you can see, we have the date of service, the date of birth. We have all the vitals in here. We have the proper diagnosis. Please make sure if they are allergic to latex or Benadryl or Tylenol, anything that our pharmacy is going to be sending, we want to make sure that the pharmacy knows they have an allergy to this. Everything else is pretty self-explanatory. I know that for most of you, this is not an area of concern as far as documenting, except that we want to make sure we document any problems the patient has. So for instance, on the neuromuscular, if they're walking with a walker, it's related to their diagnosis of CIDP, or is it related to they just had knee surgery or hip surgery? We want to know, especially in the cardiovascular area here. Their edema is always with them because they have a history of cellulitis, may be treated now, maybe it was treated in the past, maybe they have lymphedema, but we want to know, the pharmacy needs to know, the doctor needs to know, is this a medication reaction that they're filling up? Maybe they have too much normal saline going in before or after. Is this a new issue and they're filling up with fluids, or is this related to a long time issue? So things like that are very important to fill in. Please make sure that you add not only the drug, but if they're on hydration, you add that as well, because that is considered a drug. Make sure you put in your pump program, the 30, 60, 90, 20. This is what you get from the pharmacy, and it has to match, when we look at the flow sheet, this has to match what you've administered. And the two must match unless you've called the agency or called the pharmacy and got approval for a change. The pre-medication must go here as well as on the flow sheet. And again, I'll show you that in a minute. And please put something here, even if it's just 1 or 2 sentences, under the skilled nursing intervention area. The rest of this, you should know now, this time in 9:45 may be when you walk in the door. It's not when the IV starts. It's not when you're still sitting in your car. It's not when you're on your way. It's when you walk in their door. And the timeout is when you're done with your cleanup and you're leaving the patient's apartment. So if you have any questions with how to fill any part of this assessment out, I will be available to answer that. Unexpected deviations. So here's where we have those one-off situations or two-off situations, and we want to make sure we document reason for any patient delays, and I'm going to show you in a minute where to document and how to document. Any access difficulties. Patient was very dehydrated. Patient portacath was clogged. That took extra time, either with extra heparin or now you have to stop attempting and we have to order some cath flow, whatever the difficulty is. IV infiltrated, that's an unexpected deviation. Now you have to start a new IV, that's taking longer. Any adverse reactions, these absolutely must be documented, because if they're having an adverse drug reaction, the pharmacy's got to let the doctor know, and I'm sure there's going to be a change, whether it's just adding hydration, whether it's just adding Solumedrol, whether it's slowing down the infusion for the next time and this time that you're in. Whatever the reason is, they may just change the drug altogether. They may stop an IVIG or an IV at all, just for an oral med, depending on what the adverse reaction is. So that absolutely, unequivocally must be documented. Again, any reason for pausing the infusion at all, whether it's a vital signs fluky reading, whether it's pausing for the restroom, infiltrated IV, whatever the reason is, we must document that. Any reason to call the agency or the pharmacy for medication or supply issues. I've gone into patients' homes where there were not all the supplies I needed. So you must contact the agency, you must contact the pharmacy. Don't just ever leave the patient's home. We have to let the agency know. The saline isn't in the home. This happened to me just recently. The normal saline isn't in the home. Patient is supposed to get 1,000 mLs. I can't give the drug without the hydration. So even though all the other supplies were there, I could not administer this IVIG. So you must let the pharmacy know and the agency know. So here's an example of the flow sheet. We're going to go over this for a minute. Again, the name and date of birth must match from the first page. The medication must match. The dose must match. And make sure here is where you document the access point. This over here, the start time, is not when you walk in the door. This is when the IVIG started. So I want to make sure everybody's clear on this. So you want to document here when you walk in the door and when you're doing the vitals, and then when the hydration and the pre-meds are started. That goes here. 10:45, the pre-med was administered. 11 o'clock, hydration is started. Hydration on this case took 45 minutes. At 11:45 on this line, IVIG is started. That's what must match up here. The start time of the IVIG that you're administering and the end time of the IVIG. So if you're giving post-infusion hydration and the infusion ended at 5 o'clock, that gets documented somewhere else. But here, 4 o'clock is when the IVIG ended and the post-infusion started. If that's not clear, again, please get with me through email or text or through Betty, and I'll make sure that I explain this to you. Pre-meds all go here. Benadryl, but also your Tylenol would go here. Any PO and any IV pre-med would go in this space. So again, on this, you want to make sure that you're documenting the vitals every 15 minutes for the first hour, generally every hour after that, unless they're spiking or you're pausing, then you must redo the. So in other words, if you're at hour 2 to hour 3 and it's only 1 hour apart, but let's say they spiked a blood pressure or a temp or a pulse rate for any reason, then maybe every 5 to 10 minutes, you're rechecking that vital sign. You're not waiting an hour and keeping that IV off, paused for an hour. No, you're letting the office know immediately, I'm pausing it because the blood pressure went up. And then you're going to keep rechecking that blood pressure and keep the office and or the pharmacy up to date in the moment, aware that okay, after 15 minutes, the pulse rate went down or the blood pressure went down or the headaches resolved, then the pharmacist will give permission whether to restart that IV. Everything is documented and everything is given by permission. You must have something written here. What I don't want to see is just a long paragraph. Walked into the patient's home, unpacked supplies, washed my hands, patient's eating lunch, unpacked, set up my supplies. All of that we don't know. We know what you're doing when you're in your prep phase. We don't have to see that in a paragraph. This side is only related to what is happening with the patient at the moment that you're doing their blood pressure and the rest of their vitals. Because if every time you get up to this 120 mark, let's say for instance, their blood pressure spikes, we have to notify and document that this is a medication reaction. It may still be within normal, but every time you get up to that number, something happens that the blood pressure or the pulse rate or a temp spikes, then we have to let the pharmacy immediately know. You may have to pause it. You may have to add hydration. You may have to just not get up to the 120. We may have to keep that at 90 or 100 for this patient and only for this patient. Everything is patient specific. So it's very important that we document patient was just ambulating to the restroom, and that's why maybe they're out of breath. Maybe their respirations went up to 24 because this patient has a history of COPD or asthma. And yes, their respirations are up, their pulse rate is up, but they were just ambulating to or from the restroom. So again, everything that the patient is doing while you're doing those BPs, that's what goes into this last column over here. And again, it's very important so we know why there's changes up or down. Okay, whoops. Acceptable abbreviations over here. Now, we should all know what all these abbreviations are. Diagnosis, symptoms, treatment, history. There may be some that I've left out. Please, when you're adding abbreviations into a legal document, which is your nursing note, they must be completely legible, especially the C with the line over it, the S with the line over it. These can definitely be misconstrued during our internal audit, during the doctor's fast look, during the pharmacy's audit, during an external audit, because agencies do get audited. So we must make sure our handwriting on these abbreviations are very, very clear so that they're not misunderstood. On the left here, I have unacceptable abbreviations and what to do instead. So we can no longer put OD or QD for daily or QOD for every other day. We must write out daily and every other day. Same thing with BID, TID, QID. I know a lot of us in nursing school learned these abbreviations. You can do it for your own personal references, but for our legal documentation, we must write out 2 times a day, 3 times a day as such. Micrograms, we must write out either micrograms or put MCG. We cannot use that symbol anymore. Units or international units must be spelled out. The zeros, okay, before and after a number, very critical. There have been a lot of pharmacy errors because of this. A 1.0 or a 2.0 can be misunderstood if that dot is in the wrong place or too faint or too tiny. The pharmacy might think it's a 10 or a 20. So please just put a 1 or a 2 and do not include the 0.0. And it's the opposite for a 0.1 or a 0.2. We don't want that to be misunderstood as 10 times the amount. So we must put the 0.1 and the 0.2. The rate, arrow up and arrow down, we all know that that means up and down. So you can do that for yourself, but on a legal document, we must write out increased or decreased. And the same thing with this little circle. When you put, for instance, 24 hours, we know that little circle means hours, but in a legal document, we must put 50 mLs per hour or 200 mLs per hour. That little circle can get lost in your scribbles, either from the line above or the line below, and then we're left questioning, what is the rate? I have a document here for side effects that everybody will get a copy of. It's your mild when not to worry, your moderate when to start worrying, and your severe when you need to notify somebody. So you're not just worrying and pausing, but you're notifying the office and you're notifying 911 and you're notifying the pharmacy. So everybody's on the same board with any side effects versus adverse reactions. So you'll all get a copy of that if you want to. Okay, now we are all receiving in our emails this post-infusion assessment. This is very, very important. We're going to start filling this out so that we know in the moment and so that your legal document has an explanation for what you did, how long it took, and any difficulties that you experienced with this patient during this infusion. So the name and the date of service, and if this is a 3-day or 4-day or 5-day infusion, which day are you on? This needs to be filled out every single day for that infusion. All 3 days if it's a 3-day infusion, all 5 days if it's a 5-day infusion, because anything can happen on any one of those days, independent from the other days. So you're putting your medication here that you're giving, your dose, your max rate that you infused at. So if it does not match the titration order from the pharmacy, we're going to be questioning this. If the pharmacy said max at 90, but you ran it at 120, we better know that in the office, we better know that in the pharmacy, patient requested it and I got permission. Or so you would put per RX approval, per MD approval, per agency notification, but you don't make that determination on your own. That is only going to come from pharmacist and MD approval. And the same thing if it's lower, if the pharmacist sends you a titration order that says max rate 250, but you only ran it at 120, there better be reasons for it down here. And we'll get into that in a minute. Again, you don't slow it down. If all the vitals are within normal limits, then there's no reason for us to slow down an infusion. The pre-meds and hydration. Only if your pre-meds are IV push do you need to give that. Put that down here. You don't need to put your Tylenol PO, your Benadryl PO, anything else PO, because here what the pharmacy wants to see is how long did this actual infusion take. So the total time of the infusion, 5 hours, 15 minutes, including pausing infusion 2 times for 15 minutes each time. Okay, so this is the medication and hydration and any pauses. Side effects, I put in unnoted. Infusion issues, here's where you would put patient is a difficult stick, patient was very dehydrated, peripheral IV infiltrated, new peripheral IV inserted, portacath was clogged, had to use the cath flow for an extra 30 minutes. Here's where you would put any reasons for any extra delays. Any pump issues, pump beeped down occlusion several times, pump kept beeping air in line, whatever the reason is, if there's any pump issues, that goes here. And any other reasons for any delays. So for instance, I put here, patient needed extra time to hydrate and sit with heat on arm to start the peripheral IV. Or infusion was paused 2 times, 15 minutes each, for the patient to ambulate with walker to the restroom. So again, I know that we documented it on the last page, but this is again page 2 for consistency and accuracy. We want to make sure any infusion issues, any pump issues, any patient issues is documented. Any reason for us to be charging more to the pharmacy, who charges more to the insurance company, everything has to be explained. And anything else we need to be aware of, that's anything that you can think of that we left out. Patient routinely needs additional time for prepping peripheral IV site and for restroom breaks. So for this patient, then if we see the pharmacy sees and the insurance company sees that they're paying an extra hour each time for this patient, then, and that can probably be avoided. Maybe next time they'll send a pouch with a fanny pack or a shoulder pack, so that we don't have to keep infusing in the bottle on the IV pole if this patient is one that gets up and paused so often for the restroom or for any other reason. Then we're going to shift, or it's actually not even our choice. They may say we'll continue to pay the extra hour if needed, or they may say, no, we don't want to pay the extra hour. We're going to change how we're administering it. So again, that's why we need to have that information over there. Okay, so that is my summary. Just remember to be diligent, be curious, ask, be appropriate. That's with the medication, with the documentation, with our bedside manner. Be complete, be respectful, please, and be timely. Again, that's setting up the appointment, confirming the appointment, coming when you say you're going to come, letting the patient know if you're running late or running early. Can I come earlier? I finished my last infusion, or my last patient had to be rescheduled. Can I come 2 hours early? Please don't just show up 2 hours early. Ask the patient. I hope you enjoyed this training. And again, if you have any questions, I'm happy to be available by email, by text, or by phone. And I'm happy to come with you. If you have any difficult patients, I'm happy to use Shadow Me. If you have any concerns or want to boost your confidence, your skill level. And that is all I can share. So be safe out there, be happy out there, and I look forward to meeting all of you soon.